Is it clear? Audio video is clear. Can we start? Is the audio video clear? Can we start? Please reply. Okay, okay, let's start it. Dr. Mehta has given us clearance. Okay, let's start it. First of all, let us discuss hysteroscopy. FMG and NEET PG both are very fond of asking the questions on hysteroscopy. Let's see. Now, in the hysteroscopy, good evening, Isra. Let's start it. In the hysteroscopy, we put the scope inside the endometrial cavity, right? So, and we diagnose all the problems related to the endometrial cavity. Okay. So, what all problems are basically limited to endometrial cavity? It is diagnostic for which problem? Can you tell me any? For septate uterus. Okay, it is diagnostic for septate uterus. Okay, what right? And along, if we use it, yeah, it is also diagnostic for Asherman. Very good, very good. It is also diagnostic for Asherman. In Asherman syndrome, we see adhesions. Okay, so it is diagnostic for the endometrial cavity problems, right? And then if we use it along with laparoscopy, and chemoperturbation, it becomes the best test for the infertility. It becomes the best test for the infertility then. It becomes the best test for the infertility. If we use this hysteroscopy with laparoscopy and chemoperturbation. Okay. Now you tell me, by using instruments, then we can operate too. We can operate too in the endometrial cavity. When we operate, all these are PYQs. When we operate by using hysteroscopic septal resection. Okay, hysteroscopic septal resection is the best treatment for septate uterus. Okay, we don't do meteroplasty. Okay, what is meteroplasty? What is meteroplasty? Meteroplasty is doing the surgery with the myometrium. In septate uterus, we don't need to handle the myometrium. Only handling the septa is enough, and we remove the septa by hysteroscopic septal resection. For which fibroids we use hysteroscope? The hysteroscopic removal of fibroid is for which type of fibroid? Mainly there are three types of fibroid: submucosal, intramural and subserosal. So, hysteroscopic removal of fibroid is for, no, it is not for subserous. Beta, submucous are the fibroid which are inside the endometrial cavity. Okay, hysteroscopic removal of fibroid, these are exclusive FMG questions. Hysteroscopic removal of the fibroid is for submucosal fibroid. Okay, because submucosal fibroids are in the endometrial cavity. Okay, Dr. Medha, are you there? Then which is the best endometrial biopsy? Which is the best endometrial biopsy method? Which is the best endometrial biopsy method? It is hysteroscopic endometrial biopsy method. Okay, it is 100% sensitive. Okay, this question has also come, that if a patient is coming with menorrhagia or DUB, which is the best method to take endometrial biopsy? Okay, it is the hysteroscopic endometrial biopsy. Then next is if the copper T, there is missed thread, then how you will take out that copper T? If that copper T is inside the uterus, the thread has been missed, and on scan the copper T is inside uterus, then we will take out with copper T hook and ultrasound. If even that is not possible, then the method which we use is hysteroscopic copper T removal. Hysteroscopic copper T removal. Is it okay? Is it okay? These are the 4 procedures mainly which we do hysteroscopy. Once again, number 1 is hysteroscopic septal resection for the septate uterus, submucosal fibroid removal, okay. On all this there is one PYQ. Hysteroscopic endometrial biopsy is the most sensitive, 100% sensitive method, okay. And if the copper T is inside the uterus and the thread is missed and it is not being removed with copper T hook, then of course we will do the hysteroscopic copper T removal. Okay, okay. Now see, whenever we are putting the hysteroscope in the in the uterus, or we are putting the laparoscope in the peritoneal cavity, okay, when we are putting the hysteroscope in the endometrial cavity, or we are putting the laparoscope in the peritoneal cavity, then we need to distend the peritoneal cavity. We need to distend the peritoneal cavity, okay, or the endometrial cavity, whatever we are using, right? And we distend that cavity by distension media, and to keep it distended we need to maintain a pressure. Question has been asked on the medias quite a lot of time. Okay, okay. Now let us study. What is the distension media in laparoscopy? What is the distension media in laparoscopy? When we are distending the peritoneal cavity to see the peritoneal cavity, to operate the peritoneal cavity, what is the distended media? Tell me. What is the distension media? It is a gas. Okay. Which gas it is? Carbon dioxide. It is carbon dioxide. No, beta Isra, we are talking of laparoscopy, peritoneal cavity. Okay. We are talking of peritoneal cavity. Why we use carbon dioxide? Because in the carbon dioxide, because carbon dioxide, first answer, it is cost effective, okay, and it is non-inflammable, so it does not produce any accidents, okay. And what is the pressure? Again FMG question. This gas was not asked, but the pressure was asked. In the laparoscopy, the pressure is 10 to 12 mmHg. Okay, is it clear? For what procedures? For what procedures? Gynae procedure we do? Why laparoscopy? Dr. Isra is asking why laparoscopy is contraindicated in heart diseases. Can anyone help me to answer this? Why laparoscopy is contraindicated in heart diseases? Dr. Isra, I have written here above. Laparoscopy always require general anesthesia, and general anesthesia will be given only if the vitals are stable. In heart diseases, if when we are giving the general anesthesia, we have to stop the heart to function on its own. The heart is on artificial ventilation. If it is a diseased heart, it will require a long ventilator for 2-3 days. Okay, so we don't want that, right? So only if the patient condition is stable, then only we will give laparoscopy. That is why in effect topic it is written that the patient is vitals are deranged, then we will not do laparoscopy. Okay, we will not do laparoscopy if the patient condition is not stable. We will do laparoscopy only if the patient is stable, right? Because laparoscopy requires general anesthesia. A general anesthesia is something complicated. What is the benefit of laparoscopy? This was INI set question, November 22. Basic things are asked in every exam. Why laparoscopy is benefit? Yes, every laparoscopy requires general anesthesia. Okay? Why laparoscopy is more beneficial than laparotomy? No, beta. More important reason. Why lepro is good than laparotomy? Can anybody help me? This is Aina set November 22 question. Very simple. In laparoscopy, incision is very small. So, patient hospital stay decreases. Hospital stay decreases. Patient morbidity decreases. Whenever we do laparoscopic surgery, even if we do Verdein's hysterectomy by laparoscopy, patient starts walking very comfortably the next day. Okay, so that is why, because patient morbidity is very less, that is why always laparoscopy is preferred. So the two answers are that patient hospital stay decreases and patient morbidity decreases. Because if we are doing Verdine hysterectomy by laparotomy, if we are doing the Verdine, yeah beta, of course, adhesions are formed in laparoscopy also. Okay, see, I tell you, if I am doing Verdine's hysterectomy by laparotomy, okay, then the patient will get discharged from hospital after 10 days. If I am doing Verdine hysterectomy by laparoscopy, then the patient will get discharged from the hospital very next day. Okay, so you can imagine if the patient is staying in the hospital for 8 days, patient will take rest in the home for 30 to 60 days. Okay, and laparoscopy patient can go and join its work after 7 days. Okay, so the answer is number 1 is patient hospital stay decreases, and on the number 2 is patient morbidity decreases. Okay, so what is the pressure maintained not only in the gynae surgery? What is the pressure maintained in all laparoscopic surgery? It is 10 to 12 mmHg. And what is the gas used? It is carbon dioxide. Okay, carbon dioxide. And what are the gynae procedures we do by laparoscopy? Can you tell me? It is used for subserosal fibroid and for perforated copperty. Copperty which has gone into the peritoneal cavity. Yes, we also use it for endometriosis. Okay, but that fibroids have been asked. Fibroid wala was the PYQ. This is PYQ. Okay. Now let us discuss hysteroscopy. As we read that in the laparoscopy we have to distend the peritoneal cavity by the gas. In the hysteroscopy we have to distend the endometrial cavity. Okay, we have to distend the endometrial cavity, and we distend it by liquid. We don't distend it by gas. We distend it by liquid. Okay. And if we are using, this is NEET PG PYQ. It is expected in your exam also. Same are the examiners. If we are using unipolar cautery, then the media which can be used is glycine. Okay, glycine. If we are using bipolar cautery, then we can use the ionic media, normal saline. Okay, Question has come on bipolar cautery. This was the PYQ. Question has come on bipolar cautery. If we are using the bipolar cautery, the media which is used to distend the endometrial cavity is normal saline or RL. You can say it has to be ionic. See, bi matlab two. Bi means two. Ionic, there are two ions present. Okay. Unipolar means that the media cannot be separated. We have to use the non-separable media, glycine, sorbitol. Okay. What is the pressure maintained? It is 75 to 100 mmHg. 75 to 100 mmHg. This was the PYQ of FMG. Can the uterine surface be seen on hysteroscopy? Can the uterine surface be seen on hysteroscopy? What all are the structures we see by hysteroscope? Okay, we can see endometrial cavity. Yes, it cannot be seen. What all are the structures we see? We can see the endometrium. We can see the cornua. We can see the submucosal fibroid. But we cannot see the tubes. We can see the cornua, but we cannot see the tubes. Okay, tubes are very narrow. Now let us discuss HSG. Okay, let us discuss HSG. HSG is the investigation of choice or first investigation for, tell me, is the first investigation for tubal patency. It is the first investigation for tubal patency. Okay. As the patient suffers pain during the cannulation. Okay. What we do while doing HSG? We insert a cannula. What is the name of the cannula? Can you write down in the chat box? What is the name of the cannula? Leach-Wilkinson cannula. We put this cannula on the cervix and via its distal end. This is its distal end. We insert, very good. It is Leach-Wilkinson cannula. Okay, this is FMG PYQ last year. June 22. Okay, that is why I told you that FMG people are very fond of asking hysteroscopy, laparoscopy, HSG. Okay, so you have to tell me, from this distal end, we put a radiological dye. Then the dye goes into the uterus and then in the fallopian tubes. And if the dye comes out, tubes are patent. And if the dye does not come out, the tubes are not patent. Okay. HSG images we will discuss in Mullerian anomaly. What is the dye used? What is the dye used in HSG? Of course, because we are taking the X-rays, the dye will be radio opaque dye. Okay. No. Dr. Isra, methylene blue is used in chemoperturbation. This is HSG. In HSG, the dye is radio opaque. Okay. Please clear your concepts. Now, Okay. Now, just tell me, if on the HSG cornual block is coming, then what is the next step? If on HSG bilateral cornual block is there, what is the next step? It is very normal. 3 times PYQ has come on this concept. 3 times PYQ has come on this thing. If on the HSG, they say that infertility patient HSG was done and bilateral cornual block was there. Why there is bilateral cornual block? because whenever we put that Leach Wilkinson cannula, the patient has lot of pain. So the cornua, they go into physiological spasm. Please mind this thing. Physiological spasm. Why it is normal to have bilateral corneal block in HSG? Because patient suffers lot of pain, and due to that pain, the patient cornua goes into physiological spasm. Okay? Your topic from which the PYQ has come should be thoroughly clear. Okay? So if once the physiological spasm has occurred, then we have to clear it by the another advanced diagnostic procedure. What is the another advanced diagnostic procedure? Diagnostic laparoscopy and chemopertubation is the next step. So no, we cannot diminish the spasm, beta. We cannot diminish the spasm. We have to go for the second test. We have to go for the second test. We have to go for the second investigation, the more painless investigation, and that is diagnostic laparoscopic and chemopertubation. Okay, what is the next test? Write down in the chat box. Dr. Medha, Dr. Isra, write down in the chat box. It can be anatomical, it can be physiological, but we cannot differentiate. Okay, so yeah, I will be explaining it. I will be explaining it, Dr. Medha. But if on HSG there is bilateral corneal block, you will not confirm the diagnosis there. You will do diagnostic laparoscopic and chemopertubation. Is it okay? Is it okay? Okay. When is the HSG done? When is the HSG done? When is the HSG done? HSG is done at day 5 to day 11. HSG is done from day 5. No, beta, it is not done in tubal block. HSG is done from day, it is done in infertility, and it is done in the patient from day 5 to day 11. Okay, it is also known as post-menstrual, because after 14th day the lady can conceive. This is very expected question this time. At what day of the LMP we do HSG? Because we don't want the patient pregnancy to interfere, and the lady gets pregnant around day 14. Okay, so we do it before day 14. Okay, and after the periods, after period means day 5. So we do it around day 5 to day 11. Beta, this duration is also known as post-menstrual. This duration is also known as post-menstrual. Okay, this duration is also known as post-menstrual. Please don't get in exam confused by premenstrual. What is the test we do in premenstrual period? Can anybody help me? What is the test done in premenstrual period? Beta, at the same time it comes out. When we are cannulating, at the very same time it comes out. What is the test done in premenstrual and post-menstrual period? Yes. Dr. Medha, can you help me? Endometrial biopsy for the luteal phase defect. Endometrial biopsy for the luteal phase defect. Okay. And post menstrual is done HSG. Please revise it. Okay. Why we do for beta only we are adding 10 ml of the dye. We add it in a diluted form. So nothing to worry. Okay. What are the contraindications? What are the contraindications? Of course, pregnancy is the contraindication because we do this investigation for beta infertility. So it is might that we may interfere the pregnancy. So pregnancy is a contraindication. Infection is always a contraindication. Very good, Dr. Medha. Infection is always a contraindication for any invasive procedure. Okay. Active bleeding. That is why we don't do in the menstruation period. Day 1 to day 4 we don't do. Dye allergy. If the patient is having a dye allergy, and please remember this PYQ is can be there in your paper. Known case of untreated genital TB. There is untreated genital TB. Yes, very good. This is untreated genital TB. Treated genital TB. In the case of treated genital TB, we can do the HSG. That's all about HSG. Now let us do the Dr. Medha topic, chemoperturbation and diagnostic laparoscopy. Okay, chemoperturbation and diagnostic laparoscopy. Now what is here? In this, with the help of the same cannula, Leach-Wilkinson cannula, we put the methylene blue dye, and with the help of the laparoscope, we see whether the dye is coming out of the fimbria or not. See, this is ovary. This white colored structure is ovary, and this wavy colored structure is fallopian tube. Okay, and this blue colored dye has come out. This blue colored dye has come out. Okay, so this is chemoperturbation. Chemoperturbation means a dye in the tubes has gone and which we are seeing. Okay, and because this procedure is done in general anesthesia, so there is no physiological spasm, and it is the best test. Why this procedure is done in the general anesthesia, beta? Because again we have to see the dye is coming or out or not, and we have to insert laparoscope. Okay, and the dye used is methylene blue. Is it clear, Dr. Medha? Is it clear? Laparoscopic chemoperturbation is clear? Okay, when we will say the tubes are patent, okay, once they have asked in FMG that whether we are seeing the peritoneal spill by hysteroscope or laparoscope, we always see the peritoneal spill by laparoscope, because once the dye comes out of the fimbria, it is in the peritoneal cavity. So we see it by laparoscope. Okay. Peritoneal spill of methylene blue tubes indicates peritoneal spill of the methylene blue dye indicates patent tubes. Okay. Okay. So let us revise all these things. What we do that's all for today. We will be continuing with mensuration in the evening class. Okay. Hysteroscopy. We see the endometrial cavity. Okay. It is diagnostic for septate uterus and Asherman syndrome. Please write down in the chat box. It is diagnostic for septate uterus and Asherman syndrome, and along with laparoscopy and chemoperturbation, it is the best diagnostic modality for infertility. We can also operate with the help of the hysteroscope. What are the operations we do? For the septate uterus, we will never do meteroplasty. Meteroplasty means handling the myometrium. Myometrium is perfectly normal in the septate uterus. So the procedure of choice is, write down in the chat box, hysteroscopic septal resection. We can remove submucosal fibroid. The hysteroscopic endometrial biopsy is the 100% sensitive method. If misthread copper-T is present in the uterus and is being not removed by copper-T hook or ultrasound, then we can remove it by hysteroscopic copper-T removal. The distension media used for the hysteroscopy is liquid media. Okay. And if it is a unipolar cautery is used, then the media used is glycine or sorbitol. Okay. And if we are using bipolar cautery, then the media used is saline or RL. Okay. The pressure is 10 times as we use in the laparoscopy. It is 75 to 100 mmHg. Uterine surface is never seen in the hysteroscopy. If we are performing laparoscopy, we always perform it under general anesthesia, and we will do it only if the vitals are stable. The greatest advantage of laparoscopy is decreased hospital stay. The distension media used is carbon dioxide because it is very cost effective and it is a non-inflammable gas. The pressure is 10 to 12 mmHg. The gynae procedures done are subserosal fibroid and the perforated copper-T. The HSG is the first test or investigation of choice for the tubal patency. If the patient has bilateral cornwall block, then it does not mean in that it is a bilateral cornwall block. There are chances that patient has gone into pain due to the physiological spasm. Physiological spasm is there due to the pain. So the next step is diagnostic laparoscopy and chemoperturbation. This is the cannula which we use for inserting the dye via the cervix. The dye in HSG is radio opaque. In HSG, we are taking the X-rays. Okay. HSG images will be done later on. HSG is done in the post-menstrual period from day 5 to day 11. If you have to choose only one answer, then choose day 10. Okay. Contraindication. No, physiological spasm. Dr. Isra is asking physiological spasm will be present on one side. No, beta, never. Physiological spasm, if it is present, then it will be present on both the sides. The contraindication of HSG is pregnancy, PID, active bleeding, dye allergy, and untreated genital TB, not the treated genital TB. Okay? This whole page is very, very expected in your exam. The test which we do in the premenstrual period is to see the secretory endometrium, that is the luteal phase defect, okay, or the endometrium which we see for the ovulation, for the progesterone effect, that we do for the premenstrual period. HSG is done in the post-menstrual period, okay. This is laparoscopic chemopertubation. Laparoscopic chemopertubation and diagnostic laparoscopy is the best test for tubal patency. The dye which is used here is methylene blue. The peritoneal spill of methylene blue dye indicates patent tubes. Okay, and the dye spill is seen in the peritoneal cavity via laparoscope. Okay, so is that okay? See you soon at 6:30. Till then, let me handle my patients. Is there any query or I can leave? Any query, beta? Thanks to you also for being patient and attending the class. Any query? Or I can close the session. Okay. What is premenstrual? Premenstrual is day 14. Premenstrual is after day 21. Okay. We use the best test for ovulation is endometrial biopsy, changes of progesterone, to see what all the progesterone has changed. We know that progesterone makes the endometrium secretory. Okay, so if we see on the histopath that whether the endometrium is secretory or not, that we will see it in the... No beta, we usually do it in infertility patients. Okay, we usually do it in infertility patients, but we cannot check the progesterone effect in the post menstrual phase. Is it okay, Dr. Isra? We cannot check the progesterone effect or ovulation effect in the post menstrual phase. In the first 14 days, we cannot check. We have to check it on the day 21. Okay, so there is no alternative, right? So post menstrual done is, write down in the chat box, Dr. Medha, post menstrual which test is done? Pre-menstrual which test is done? Can I close the session? Yes, very good, very good. Can I close the session? Dr. Isra? Okay. So good day. Bye bye.